We've still got quite a few people entering, so I'm going to give it another couple of minutes. But while I see that we've got Savannah with us, so while I'm just admitting a last few people, we've got an interesting afternoon today, starting with Savannah Chakravorty talking about sibling allogeneic stem cell transplants at King's, but also paediatric and adults more globally. There's a nurse's perspective, a psychologist's perspective, and then Dr. Victoria Potter is going to update us on haplodonor stem cell transplant as part of the redress trial. So I think most of us are here now. So if I could hand over to Savannah, she's our one of our paediatric haematology consultants at King's with a specialist interest in red cell disorders, and she's also helping lead the red cell transplant service. Over to you, Savannah.
Hi, sorry, can you hear me?
Yes, nice and clear.
Thank you. I'd like to thank Sarah and everybody else who's asked me to do this presentation. I'm a little bit of an interloper here, having done BMT work in my previous role as a pediatric hematology consultant at St. Mary's Hospital, where I was involved in the transplant program involving children who were undergoing transplant for sickle cell and thalassemia. And I've been at King's for 7 years this week. Time's flown really quick, but in the last year or so, I've joined Transplant again, and that's thanks to Dr. Potter, who is the BMT director at King's, for for all the work that's gone in by Dr. Potter and others in Southeast in the Southeast Thames region, really to try and get bone marrow transplant available for adult patients in sickle cell disease. So although, and Dr. Potter is going to speak specifically about a very exciting transplant trial that's coming up, being made available nationally very soon, where Dr. Potter is the chief investigator. I'm going to talk a little bit about it. I'm going to kind of give you an overview on bone marrow transplant in sickle cell disease as a whole, across all ages, and just kind of open your maybe in your own minds the idea of where you would place transplants in the algorithm of treatment for patients that with sickle cell anemia. And so I'm going to share my screen. Can you see this?
Yes, we can.
Yep.
Thank you.
Okay, lovely. So this is I've got 20 minutes, so I'm going to be quick. There are quite a lot of slides to get through. I'm very happy for these slides to be shared. This is all publicly available data. I'm also going to use some case studies, which are anonymous case studies that I've been involved with in my in my few years of doing transplant, both in pediatrics and in adults. So these are anonymous cases, just really demonstrative of the kind of points I'm trying to make. So some of them, one or two, are actually just prototype made-up cases. So just really to illustrate points and make it a little bit more interesting for people to hear. So I don't really need to dwell on this, but it is a very exciting disease, and it has excited sort of academic scientists, thinkers, activists, anybody really, and sickle cell doctors and nurses like us here present in this meeting today. And you all know this, that it is a multi-organ disease. It affects everywhere. Main thing is this sort of polymerization of the deoxygenated hemoglobin molecules within the red cell, causing the change in the shape of the cells, and then leading to blockage, poor flow of blood, activated cells, and damaged endothelium. And again, this is just to really give you, and many of you, perhaps most of you, will have seen this diagram just to illustrate that actually we only see very, very, very tiny amounts of sickle cell compared to the rest of the world, the most being in Africa and India. So just to next slide. And as we know that it is a multi-organ disease, hemolytic anemia, susceptibility to infection, basic risk episode, chronic organ dysfunction. And with in the 70s, it used to be a childhood disease because nobody survived through to adulthood. But of course, with time, that has significantly changed. And by the 90s, we were seeing, significant advancements of mortality in childhood. Although what we've effectively done is pushed the morbidities from a childhood age over to the adulthood age. And that the main things that have prevented children from dying are prevention of infection through antibiotic prophylaxis and immunization, hydroxycarbamide, and of course stem cell transplant. And these are just survival curves, survival diagrams, just to show you. Sorry, share again. Sorry, I'm going to have to share again. Sorry. Okay, yeah, survival diagrams just to really show you that people have gradually improved their survival, mainly through dogged simple medical care, such as diagnosis at birth and antibiotic prophylaxis and immunizations. But of course, and survival here, as you can see, the top level is the top best survival. This curve, the purple curve, is from London, the East London cohort, but it was published in 2006. So it's more than 15 years ago, and even 15 years ago, 16-year-olds were surviving. Majority of 16-year-olds were surviving at the time. And so organ damage in sickle cell is plentiful, even though children are surviving. We end up with people dying in their 40s, really people becoming significantly burdened with their disease in their 30s. And the median age of death in our sickle cell cohort within King's was 45 years in a recent study, which was published in 2016, I think. So the vast majority of the patients who are dying in their 40s and 50s. So really, all the children are surviving. The adults are not doing very well. So what we want to do is try and have a method in which, or a intervention in which we can prevent the worsening of organ damage, perhaps improve the quality of life, and perhaps even arguably improve longevity of these patients. So longevity is something I'm going to briefly touch upon later on. It's still probably not very clear whether people are living longer for having had bone marrow transplant. What we know very clearly is that people are living longer for having had hydroxyurea. There's plenty of data to support that, but we're not quite sure whether BMT is also affording the same privilege. So first reported bone marrow transplant was in a patient who had leukemia and ended up having cured of both diseases. And since then, hundreds of thousands of people have undergone BMT. And I will briefly touch upon a really large registry study of 1,000 patients on having bone marrow transplant for sickle cell disease. And overall, bone marrow transplant in children from sibling donor, taking bone marrow source and a myeloablative preparative regimen provides excellent outcomes. So very good overall survival. 94% people of the children who had the procedure will survive 5 years after their transplant. Some of them will survive, but might end up not really being completely disease-free, and very, very low mortality compared to some of the other transplant areas. So I'm going to just quickly discuss some case studies that will just give you a brief sort of flavor of what are the decision-making processes that lead to transplants. So this is a sickle cell. This is a 6-year-old girl with sickle cell anemia. She was diagnosed, in fact, through prenatal diagnosis. She had her first sickle crisis at age 4, and she was hospitalized twice. And then since then, she has had several hospitalization just for various low respiratory infection type thing. At age 5, she had an abnormal transcranial Doppler indicating high stroke risk. She also had obstructive sleep apnea symptoms and was given adenotonsillectomy. Her mother was not keen to start transfusions, so we started hydroxycarbamide at the time, which actually resulted in normalization of her TCD velocities. At that time, when she first identified to have abnormal velocities, following 3 months of hydroxyurea at fairly high doses, her MRI scan at the time when we first did it was actually normal. But a year or so later, she'd had a parvovirus B19 associated aplastic crisis. She was found slumped in her bathroom floor, having a seizure. She was taken into hospital and was found to have multiple white matter, small white matter infarcts, sort of silent cerebral infarcts in the watershed areas of the middle cerebral arteries. And then when the MRA head done at the time concomitantly was very, very abnormal, showing significant progression of disease in the last year, despite being on hydroxyurea. So at that time, she ended up with a transfusion program. Her mother agreed to start the transfusion program at that point. We also explored the possibility of a bone marrow transplant and did tissue typing for her siblings, and there was a 4-year-old sibling who was a full HLA match. So the therapeutic options at that point would have been continuing regular transfusions and iron chelation, continuing transfusion through age 18 and then change to hydroxycarbamide, non-cerebrovascular disease, so not suited for converting to hydroxycarbamide upfront, and then workup for BMT would be the other therapeutic option. So the parents opted for bone marrow transplant, which the child underwent with full myeloablative conditioning, had graft versus host disease prophylaxis, a relatively moderate cell dose, and had a good neutrophil engraftment and full donor chimerism, as was normally seen in this kind of conditioning transplants. So this is kind of a good example of how a bone marrow transplant can kind of give you freedom from diagnosis of sickle cell. So she no longer, at least in her bone marrow, had sickle cell anemia. Her brother was AA, and therefore she did not really have any measurable hemoglobin S in her blood following that. And this is just really to show further sort of information or further studies that showed what happens after BMT. Is it worth putting a child through a bone marrow transplant simply because you want, the sickle percentage to not be there, or does it really actually make a meaningful change to their organ function or to their disease state? So, this was a very large study published many years ago now. 59 patients, many centers, nearly 30 centers, received HLA identical marrows between 91 and 2000. And these were very similar conditioning to the one that I've told you about. And this showed very, very good, even back in the day, 93% overall survival. And showing that the post-BMT, that these patients did not have any painful episodes, did not have any chest crisis, no episodes of splenic or hepatic sequestration, no need for red cell transfusions, no further strokes, transient ischemic attacks, or hemorrhagic CNS events. So essentially, if you become philosophical and kind of try and work out what cure means, you could simply say cure from this condition, essentially for BMT, would simply mean cure from the side effects, also symptoms of sickle cell disease, which is what these patients achieved. And when we specifically look at stroke, I mean, there were some, in this series, there were patients who actually had clinical strokes, quite a large number of patients. Only one out of the nearly 30 patients who had stroke ended up with an ischemic stroke post-BMT. And the people who had silent strokes, such as our patient, didn't have any post-BMT. And of course, the children who did not have any strokes, either overt or silent, actually did not have any strokes either. So actually, the CNS protection following a bone marrow transplant is excellent. So this is another case. I'm just going to quickly look at my time. This is a sickle cell patient diagnosed at birth, very ill right from the word go. Was started on hydroxycarbamide, but not continued to have pain. Commenced on transfusion at age 13 because hydroxycarbamide was not controlling the symptoms. However, they developed red cell alloimmunization. It became more and more difficult to continue with transfusions. So the therapeutic options would be, improve compliance of hydroxycarbamide, increase the dose of hydroxycarbamide if possible, commence automated red cell exchange transfusion with careful red cell unit matching, or bone marrow transplant. So this child also had a bone marrow transplant from a sibling donor, and again remains cured from sickle cell disease. So this was a patient who did not have a CNS indication, a central nervous system indication, but a sort of failure of hydroxycarbamide and transfusion indication for transplant. Now, I was just going to show you this this Belgian study, which essentially kind of explored the possibility of, does giving you a transplant improve your longevity? In this study, this was not really a very well designed, this was a limitations of the design of this study was this was part retrospective study, a registry study from Belgium, which essentially showed that if you compare no treatment to either stem cell transplant or hydroxyurea, actually the people who were having stem cell transplant or hydroxyurea were surviving much, much longer. So definitely no treatment is far worse than hydroxyurea or stem cell transplant. However, they weren't able to show that stem cell transplant versus standard supportive therapy without hydroxyurea provided any survival advantage. That was partly because there were a few deaths, infection-associated deaths in this cohort. But it really kind of trying to work out, giving a transplant, of course, improves your quality of life, but does that make you survive longer? I don't think we have the answer just yet. And again, this is the study I was talking to you about. This is an international registry study, both from the CIBMTR as well as the EBMT study, really reporting on 1,000 patients having HLA identical sibling transplants between 1986 and 2013. 10% of these patients had reduced intensity conditioning transplants, and 90% had full myeloablative transplants, like the two patients I've talked to you about before. Very, very impressive overall survival and event-free survival, over 90%. And as you get older, your chance of surviving is less and less. So younger children did much better in terms of survival from the transplant procedure itself. And of course, with time, with improved supportive care, improved conditioning treatment, actually survival improved as well. So any transplant happening after 2006 was people fared better compared to before. Of this 1,000 patients, 23 patients experienced graft failure, 70 patients died, which was 7% death, and the most common cause of death was infection. So this is an interesting sort of overall view of sibling donor transplant. And this, remember, not just children, but also young adults, using both combination of myeloablative and non-myeloablative transplants. So what are the barriers to BMT? Vast majority of children who qualify for transplants do not have suitable match-related donor. So what are the other options? You can do unrelated donor, you could do unrelated cord, you could do mismatched related bone marrow donors, or haploidentical donor from peripheral blood stem cell or bone marrow. So if you're searching for a donor in sickle cell disease, BMT is very, very hard, because you may have a sibling who's a full HLA match, but unfortunately they may also have sickle cell disease, so not suitable as a donor. And so this might be a point this is certainly going to be a point I'm going to raise later on in the talk, where other alternative transplant situations are going to be taken into consideration. This is a 20-year-old lady with a long history of recurrent vaso-occlusive episodes, poor response to hydroxycarbamide. Red cell top-up transfusion program was thwarted, really complicated by difficult venous access. 3 episodes of acute chest syndrome within 6 months of stopping red cell transfusions. She had chronic sickle cell lung disease, nephropathy, and sibling is HLA matched. Now, this was at a time, this was about 10 years ago, I'm talking to you, well, about 7 years ago. This was just as I was leaving St. Mary's. She was 20 at the time. Sickle cell transplant for adult patients was not available at the time, and she was within the adult age group as she was 20. But there was at the time, while this was happening in London, an NIH-sponsored study happening for young adults with fully myeloablative transplant, fully myeloablative conditioning, for young adults looking at this very thing. Can a full myeloablative transplant, although moderately myeloablative, because lower dose of using fludarabine and rabbit ATG and busulfan in decent doses, could that be successful? So this was a 3-year trial. It enrolled fabulously quickly. 22 patients were enrolled in a matter of 3 years. The 22 median age was 22. 17 was matched HLA matched siblings, and 17 was unrelated donor, but fully matched. And survival was good. 20 were alive at 2.7 years post BMT. 1 year event-free survival was 86%, and overall survival was 91%. And I'm just not going to go into this detail, but it's really just to show that actually the comparatively the chronic GVHD in the unrelated donor, acute and chronic GVHD was not that severe. Having said that, there were only 5 patients going through that procedure. But what was really striking in this study was that the quality of life was very, very significantly improved following this transplant in young adult with myeloablative conditioning. So there was significant improvement in physical functioning post-transplant, as well as significant reduction in pain interference, meaning you can't do stuff because you've got pain. That was significantly reduced following this transplant. So something really to think about for a young adult who may be willing to undergo a full myeloablative transplant. But of course, the learning from this, is the rates of rejection is very less compared to a reduced intensity conditioning transplant, which I'm going to talk about next. Comparative rates of overall survival and event-free survival compared to international data that I've just showed you with the matched sibling data, and improvement in quality of life. So something really to think about for our very young adult patients. Another case, this is a 42-year-old male, sickle cell anemia, intermittent priapism, retinal sickle cell related vascular changes, venous ulcer, avascular necrosis, right hip replacement as a result of that, intermittent mild proteinuria, anti-E and anti-S antibody detected, and on regular red cell exchange transfusion program for management of severe sickle cell condition. So this is a reduced intensity conditioning transplant, which was published over 15 years ago now, which was piloted and sort of spearheaded by the group in National Institute of Health in Washington, where they used a alemtuzumab and low-dose total body irradiation with unmanipulated peripheral blood stem cell donor cells and sirolimus as a immunosuppressive agent, really to stop people from getting the posterior reversible encephalopathy syndrome and all the sort of CNS, post-BMT CNS problems that people generally experience in sickle cell disease. So this was thought to be reduced intensity conditioning. It's non-myeloablative. So if there was rejection, the patient's own hematopoietic stem cells sort of returned very easily without much problem. And this was the original study where the age range was anything between 16 to 45, very severe disease. And this patient, there was there was a follow-up study about 5 or 6 years down the line, 30 patients treated between the ages of 17 to 65, 29 patients survived, and 26 out of the 30 patients engrafted. So there was 87% engraftment rate, and 15 of those had more than 50% donor T cells essentially, and was able to successfully come off the immunosuppression. So in comparison to the full myeloablative transplant, actually the rate of there's high rate of rejection as well as ongoing need for immunosuppression to in this kind of mixed chimera situation where there is both donor and recipient T cells still present. And now this is another very large study who's just been published in the British Journal of Hematology. 3 centers involved in this study, one at National Institute of Health, one in Chicago, and one in Saudi Arabia. 122 patients, adult patients, match-related stem cell transplant from peripheral blood, fully matched sibling donors, and out of the 122, 16 patients had graft failure, so it's 13% graft failure rate, and 103 patients were alive and well with stable donor chimerism. So essentially, this study shows that people can undergo very safely adult transplants, for sickle cell anemia with a very reasonable chance of being cured and coming off immunosuppression. So just to say that mean donor myeloid chimerism at 1 and 5 years post-transplant were 84 and 88%, but the T cell chimerism was 48 and 53%. So again, just really mirroring what we'd previously seen, that you get about 50% stable donor chimerism, mixed chimerism but somehow keeping the patient safe and symptom-free. And basically following the transplant, a lot of post-transplant assessment in terms of organ health was very, very satisfactory, and 14 patients went on to have children, which I think is very, very reassuring in this situation. So based on this information from adult data, in 2019, we finally, after a lot of work from a lot of people, perhaps in this meeting as well, the NHS finally agreed to commission or pay for transplants for adult patients, so over the age of 18, to receive transplants from a sibling donor for severe sickle cell disease. So that was a very, very welcome move from the NHS. And as of now, there are a number of patients that have received these transplants in many centres across the country, certainly also at King's, where some of us are involved in this programme. And I'm just going to quickly move on because I'm conscious of time. This is a 6-year-old boy, never been admitted for vaso-occlusive episodes, had progressive cerebrovascular disease. Unfortunately, his sibling was not an HLA matched, so he ended up having an unrelated donor transplant. However, some unrelated donor data from prospective studies from America has really shown very, very poor outcome, particularly with death in young patients. So in this study, 7 patients died out of 23, and all of them were sort of either older teenagers or young adults. And actually, using sort of unrelated, fully matched donor transplant with myeloablative conditioning is probably at the moment not an option that is being favoured by most people. So, and this is a case that I'm going to quickly say that this is a child with very, very severe disease who does not have a sibling donor. So the other option would be to do a haploidentical transplant, which is a 50% donor match from either a sibling or a parent. And in most cases in children, there is at least one parent who's available to donate. And in adults, there may hopefully be siblings who are still able to donate. And this is a very clever way of transplanting patients where you use fludarabine, a small amount of cyclophosphamide and ATG to begin with, small dose of radiation, and then following transplant, a fairly decent dose of cyclophosphamide after the actual bone marrow transplant's gone in. So this is a very, very helpful way of increasing the donor pool where we can use 50% match with, there was some worry about increased rates of rejection in this protocol, but there are some changes in the protocol that are being considered now, which may improve the rates of rejection. So, so in summary, and just to say that Dr. Potter, I didn't mention the haploidentical trial at all, but Dr. Potter is going to talk to us about how haploidentical trial in adults may be a game changer. It will allow a lot of adult patients to have access to transplants if they don't have sibling donor. So in summary, the best outcome of bone marrow transplant is for matched sibling donor in young patients. Unrelated cord blood is very unsatisfactory outcome. Matched unrelated donor and mismatched myeloablative transplants are equally successful. Matched and mismatched related donor, sibling matched cord blood is very effective, especially co-transplanted with bone marrow. I didn't dwell on that very much for the sake of time. Reduced intensity conditioning transplants from sibling adults has started in the NHS. The initial results are very promising. Haploidentical transplant, which is just a 50% match either from a sibling or a parent, are providing access to a huge donor pool, but need to be done under research umbrella, adult trial to start very soon. And finally, just to say acknowledgements, my patients at St Mary's and King's, colleagues at St Mary's and King's, they're all there and I may have missed some, so apologies for those who I have missed. And of course, this lovely HCC, which used to be SDSTN in the past. So thank you for your attention.
Thank you very much, Savannah. That was really, really interesting and comprehensive discussion of where we are with stem cell transplants. We've gone slightly over time. If there's a couple of quick questions, we could try to address them. I can't see Alison Pratt on the call yet. So a couple of questions while we see if she's available.
I'm here.
Oh, good.
I am.
Okay. So anybody got any questions? I can see one hand up. Go ahead.
It's just Michelle here. So you just in your summary slide, but MUDs and mismatch relateds are equally successful, but not very successful, because the outcome of the SELSEHCC trial was that there was poor outcomes, particularly in the older patients. Then, so are they currently not recommended, or not commissioned, or exceptional cases?
I think the mismatch related one, I think I may have meant just sort of 9 out of 10 HLA rather than
siblings. Yeah.
With mismatch related that's what I meant. I didn't mean mismatched unrelated. Or, so certainly for the unrelated, matched unrelated, the SELSEHCC trial was really very poor.
And perhaps that's just that they were doing older patients who had lots of, who got to the transplant very late because it was their only option.
Yes, and also if you actually look at the conditioning, it was a very, very strange conditioning. It was a 21-day conditioning. I just don't know why they chose that, but I'm sure there was a rationale for that.
All right,
brilliant. We better move on now to Alison's talk. I see there's another hand up. If you could put your question in the chat, we'll come to it later. Apologies. Alison, would you like to share your screen?
Yeah. Just go. Are you able to see that?
Not quite yet, but
No.
yes, we can see just your desktop. I'll just explain who Alison is. She's our bone marrow CNS at the moment for the red cell patients, and comparatively new to that specific post. And I'm sure she can tell us a bit more of her background.
How is that?
I can just see your desktop.
Alison, if you just click on your actual presentation, as we can see your desktop, it should come up.
Yeah,
you're sharing your second screen. If you've got a second screen, you're sharing that one at the moment.
Can you see that?
Can see it now.
Can you see that now? Okay.
All right.
So with that. Okay. So as Sarah was saying, my name is Alison. I'm one of the clinical nurse specialists in the bone marrow transplant coordination team here at King's. I started in the role in January. There's four bone marrow transplant coordinators, CNSs in the team, and there's 2 transplant doctors. And my main background is actually working with hematology malignancies and supporting patients through the autologous transplants, bone marrow transplants. So today, obviously, I'll be just giving you an overview of what my role is in helping the adult sickle cell patients through their transplant experience. So if I go to the first slide, they'll have like an initial discussion with their consultant, identifying if they're interested for the actual transplant process. Once that's been identified, they will then pass that on to the transplant team, and we'll then contact the patient. We'll ask them for their details. We'll also ask for their sibling details so that we can send out tissue typing. So we do all our tissue typing through the Anthony Nolan. The results usually take about a couple of weeks. Once they come back, we have another donor team which will then contact the sibling with the details. They're then taken to their local MDT and national panel for approval. Once that's done, we'll then invite them back for a further discussion with the transplant consultant, and also to meet ourselves face to face. At that point, we can give them information booklets about the 7 steps of the transplant process, and also about the next 7 steps once the transplant process is over. Currently, the information we have is only for malignant cancers. We just have to ask them if they have any worries or anything or concerns that comes up to ask us directly, so that we can kind of reassure them that it might not actually be relevant to their situation. At the meeting as well, we'll also kind of go through potential timescales. So that's usually once you find we can cryopreserve the cells from their donor, and we can then start working on getting transplant dates for the patient. Once that's done, we then invite them for a consent stage. So we'll do their first stage consent. Once that's done, we will then go into, it will then be a hospital admission about 4 weeks afterwards if there's no complications. Then there's a discharge, and then there's twice weekly reviews of blood initially. So for the donor details, like I said, we will call the donor, ask for the sibling information, and we'll arrange for tissue typing to be done. And we then have, once the results are back, obviously inform them of the details. When the tissue type goes out, we actually have the donor fill in a health questionnaire and get them to have, it's either a buccal swab, which we can do from tissue typing, which is like a swab of their cheek, so both sides, and then we can also do it via the blood. But when we do it with the blood, we can then match the blood groups to the patient and everything. Once we've notified the donor of the results, we then kind of seek permission from them, because it's their results, we only give the results to the donor. We'd have to actually seek permission in order to be able to let the patient know themselves if they're a match or not. The donors would then have a medical assessment, so long as their health questionnaire has been cleared. So the health questionnaire is there just to give a quick screening to make sure they don't have any health problems themselves that might exclude them from being a donor. So once that's done, they will come for the medical assessment with one of our consultants. They will have medical clearance, which usually takes a couple of weeks because we'll check their bloods, check all the virology, we'll do a chest x-ray, ECG. If they're female donors, we'll have female donors before GCSF starts. They would need to have a pregnancy test. So the GCSF is what we use to stimulate the bone marrow to release the stem cells into the peripheral blood. And that is what we then use to collect. So there's no operations kind of required. We can do it all through the peripheral blood. So it's not as invasive as maybe what people might think, because there's some that kind of worried that it's going to be an operation, but thankfully it's all peripheral now. They will then have to have a COVID swab 72 hours before they get a stem cell collection, and we then actually will follow up the donor as well, just to make sure they're okay after donation. So to be able to get the patient all worked up for their actual transplant, there's a lot of hospital appointments to be coordinated and kind of sorted out for them. So they need to be aware that we try and kind of coordinate all of their workups for maybe over 1 or 2 days, that they will need to have maybe time off work, they kind of have childcare. We offer all of our patients fertility preservation. That's because they will go for total body irradiation in preparation for having the stem cells given back to them. So there is a lot involved in preparing patients for transplant. Sickle cell patients are also, compared to other our transplant patients who'll be in relatively good state of health, they may have some organ impairment that might actually have to be kind of managed or further treated before they actually go ahead for transplant. That's for there. Other things that we should really consider before going ahead for the transplant is their childcare. Do they have anyone at home that's going to be able to take care of them? Any financial concerns that they may have, if time off work, because if they can have the actual whole process can take, so 1 week for the actual conditioning, and then 3 weeks after that post-transplant to kind of manage all the side effects, if there's any side effects, and just to get them ready. So that could be a good 4 weeks off work just for the transplant itself, and then you've got the post-transplant stage where they'll still be needing to come to the hospital a couple of days a week just to have the blood results checked and their medications kind of worked with. All of our patients are referred for a fertility consultation. Just it's at low risk of becoming infertile from the actual procedure, but it's always best to get the baseline, just because you can't 100% guarantee that it won't be affected. And just for the women when they're going for egg collection, that can actually cause some painful crisis, so that just needs to be taken into consideration as well, so that it's not done too close to the actual bone marrow transplant date, in case it might delay things. Then for pre-admission, you have the consent clinic, which is when they'll see one of our bone marrow transplant coordinator doctors. They'll see myself as well. We will go through their treatment plan in detail, just to finalize it if they have any questions about the process. We will also check to see what all of their workup tests have all been completed and they're all good. We'd also check that, so just confirm they've got medical clearance to proceed to transplant. Once that's done, we would have to, they would also need red cell exchange before treatment. If they've got a kind of a difference in blood, we'd have to exchange, organize a plasma exchange, and then we'd organize COVID PCR swab as well, because that needs to be done 72 hours before admission. Then on admission day, we'd liaise with the team. The whole of the healthcare team in the hospital will be informed of the treatment plan and they were coming in. There'd be the protocol issued of the morning of treatment. There'd be second stage consent also done on that morning. There'd be transport that would be booked for their total body radiation, because that gets done at Guy's Hospital. And then the apheresis team would be notified of the admission, so that if there's a plasma exchange organised, they're prepared, and also for the red cell exchange. I think that's everything. And then if anyone has any questions as well, I know that was very brief, but
that was great. Thank you very much.
That's all right.
Really good overview of what happens. Have we got any questions?
Hi, Alison, it's Rachel Pawson. Sorry, I missed a little of your talk. So do you accept related donors with sickle cell tray for peripheral blood stem cells? And if
yes.
so, do you do anything differently? Apologies if I missed that.
Yes, no, we do accept donors with sickle trait. I think one of my medical colleagues can tell you if there's anything we need to do different though.
So I can just chip in here. So it's fine to accept AS donors, and you know, so GCSF mobilization of AS donors is also safe. So, you know, previously, you know, as you know, the sickle cell SS patients with GCSF mobilization is not done because it can precipitate acute crisis. And I think there have been 1 or 2 deaths reported on that with that. So, yeah. But with the AS donors, it's perfectly fine to do that. And there was a study about, I think 2003, 2004 in blood, which kind of basically said that was fine. So we, since then, I think AS donors are being GCSF mobilized everywhere, and of course, you know, of course, BMT, the S percentages will reflect that, but that's the only thing. Yeah.
Okay, thank you.
Thank you.
Before we move on.
Okay.
So it is now just about time to start with Philip Alexander, a psychologist's perspective on assessing and preparing an adult for transplant. So if there's no more questions, Phil, do you want to share your screen?
I will try, yes.
So Phil's one of the psychologists that's involved in assessing patients prior to transplantation at King's. I'm sure he can give you a better mini bio than me.
Right, so
you've got your desktop at the moment, but it looks like we're getting there.
Do you have that? Can you all
Wonderful.
see it? Okay, thank you, Sarah. So yeah, I'm Philip Alexander. I lead on the HemOnc side of psychology within the department, actually, and this sets up here at King's. So there's a team of psychology psychotherapy for HemOnc and a different team for sickle cell with a shared social work post between the two services. The two services work very closely together, but they're operationally separate because we're each embedded with our respective services. Typically, my service, I've been here for about 10 years now, has always worked with the transplant patients, and we see them at any point in the pathway, and we operate a very flexible, needs-based model. It should be clear today that I'm not giving a talk on the psychology of sickle cell patients today. Obviously, there's not time for that, but also I'm not the expert in that field. I understand there are probably two people on the call who are indeed the psychological experts in sickle cell disease. So I won't profess to be offering that. Other than some obvious observations, of course, we know that people living with this lung condition has a high incidence of depression and low self-esteem, the effects of pain, potentially opioid dependency, problems in neurocognitive functioning, and overall poor quality of life. That already exists before patients potentially even come into the transplant process. Just to add another couple, so basically what I'm going to do today is just describe what we do, but I'm going to add in a couple more slides just for context. So this is just thinking about the overall general psychological symptom burden for transplant patients, not just those with sickle cell disease. So even though there may not be psychiatric comorbidity commonly, there is a high prevalence of distress. You can see some figures there. It's psychological distress in transplant patients is associated with worse health outcomes, including increased mortality and a high risk of graft versus host disease. There's a study I found there which was suggesting that even about 6 months out of transplant, some 43% of patients reported significant global psychological distress in the areas that you can see there on the slide. Distress is also found to relate to things like fear of recurrence, fear of secondary cancers, body image issues, sexual dysfunction, uncertainty, and so-called reintegration into normal life. So you can see why these are all really important considerations for the sickle cell population for whom the transplant may not be seen as a critical or an imperative intervention. So since about 2016, my immediate colleague Surabhi Chaturvedi and I have developed pre-transplant assessments for our patients. Interesting, this wasn't being done when I came into post in 2012. I should be clear here when I say that we can't predict every eventuality or fix every problem, but it's very important that patients come into this process with us knowing something about them and their psychological baseline. And we weren't doing this when I arrived, and there are a couple of standout cases for me. I remember just a month before transplant, a woman had tried to kill herself by drinking a bottle of bleach, and this is something that we just didn't know about right until she got here. There was another gentleman with very, very, very severe PTSD, and the form that it presented with was in rage and anger and throwing things around the ward and shouting at people. But one thing that we hadn't known about him was that he was kept as a prisoner underground in Bosnia. So it's not that some of this information doesn't come with the patients, because sometimes it does, and sometimes our transplant coordinators are able to elicit some of it, but there was no structured format for eliciting some of these psychosocial concerns and risk factors, which is why we decided to develop this program. Unlike some screening tools that are used in solid organ transplantation, which I think I've got on the next slide, we didn't want the format to be too prescriptive, and we certainly didn't want the aim of the exercise to screen people out from transplant. I mean, from what we gather from the literature, in most centres across the world, psychosocial risk is not used as a reason to screen out patients from eligibility for the transplant. In most cases where patients, certainly with malignancies, need the transplant, they are usually given the transplant. But obviously psychosocial coping is a very important factor. So it's certainly not the job of the therapists to decide who should have a transplant. That's a decision for the MDTs led by the transplant doctors. But what, of course, what we do is we can make our assessments and make a very significant contribution to the overall decision about whether to transplant when indeed there are risk factors. Ultimately, for us, it's actually about supporting. So I suppose our presumption is that the patient will have the transplant, and what we want to do is to be able to support them through that process. These are the tools that I mentioned just briefly that are used in solid organ transplant, the SIPAT and the PACT. This is mainly kidney and liver. And as you'll see, both actually coalesce around 4 domains. The first one, social support, psychological health, and always includes psychopathology, lifestyle, understanding of transplant and what the follow-up will entail. And as you can see, the PACT has similar domains. I'm confident that the things that we ask about and look for map quite well onto these domains. Some of these questionnaires go into very great depth. For example, something like alcohol use, you can see why, I guess, with liver patients, exactly how much, when, and everything's rated and everything's scored. And at the end of this very lengthy assessment, you get a score, and the score will determine whether you should remain on the list or possibly have a transplant or be removed from the list. And I just want to be clear that that's not quite how our assessments function. So what is our rationale? It's to identify psychological and psychosocial risk factors, as I've mentioned, which may affect the patient's ability to cope. It's essentially to ensure that they're offered appropriate psychological support and interventions in a timely way that may reduce the so-called psychosocial risk, but more importantly, to help with the rigors and demands of treatment. As I've already mentioned, it's to contribute to the MDT's overall holistic understanding of the patient and potentially about their suitability for a transplant. And for me, this last point is really important too. It's about not normalizing psychology and psychotherapy for patients, so that we are seen as an embedded and a normal part of the team. And certainly in the years that Sarabi and I have been doing them for malignant patients, we've noticed that it's been really helpful that the patients already know us, they have an existing relationship, or they've at least had an introduction. So if we rock up on the ward, it's kind of more normal and less threatening. What sort of psychosocial risk factors may affect a patient's ability to cope? I don't suppose any of these will surprise you. Obviously, active suicidalization is a really important thing. Serious mental illness that's not well managed. I mean, it's important to highlight that. Often it's reasonably or very well managed, and it should not preclude people from an essential transplant. Certainly, that decision might be more nuanced, potentially for sickle cell patients. We might think about whether people have the capacity to make informed decisions, particularly if there are kind of intellectual disabilities or social impairments, usually attributable to something like autism. We will ask questions about illicit drugs or alcohol use. Social support is a very important thing to inquire about. Unstable social circumstances. We ask about attitude towards the transplant. Is there extreme ambivalence? Is there reluctance? Is there poor motivation? Is there something like extreme pessimism or fatalism, because those things are predictors of depression? Is there a known history or pattern of non-adherence? Is there an aversiveness to hospitalization more generally? So what support will be available? Will there be a range of psychological interventions, therapies available? And then it may necessitate a referral on, for example, to our social worker or to psychiatry. Sorry, there's a noise outside. We may try and find out if there is mental illness, if a patient is known to psychiatric services already. So we'll try and get some collateral additional information if necessary. One thing, I'm not sure where I was going to mention it, but I'll mention it now, is that as the pathway developed for sickle cell patients, we built on the work that Sarabi and I had already been doing, and we worked closely with Gary Bridges, who was heading up our sickle cell psychology at King's at the time, and Heather Rawle, who heads up sickle psychology over at GSTT, and we tweaked and developed our pathway and our SOP. But what we also decided from the get-go is that we'd collaborate very closely with each other to find out, for example, from the hem-onc side, as it says there, the pre-transplant CNSs, one of whom is Alison, will routinely make referrals to the HEMONC service for pre-transplant assessments as early in the pathway as possible, that it's known that the patient is going to have a transplant, so possibly as much as 3 or 4 months in advance of the transplant. Typically then what Sarabi and I will do is liaise with the sickle cell psychology colleagues here at King's and at GSTT to see if the patient is already known, to see if they're known very well. Maybe those sickle cell psychologists can already provide the information, and whether it's appropriate to go ahead with a new routine assessment and who is best placed to conduct those assessments. We've only had small numbers so far, and I'll come on to that in a minute, and thus far it's made sense for the HEMONC therapists to conduct the assessments because we have the most experience in doing so. But then we would continue to liaise with sickle cell psychology colleagues to see who is best placed to provide any ongoing support if needed. As you can see from the slide there, the patient is contacted by us, hopefully already having been primed by the CNS that we're going to do so. And then some self-report questionnaires are sent out to the patient and the clinical interview is arranged. From our perspective, when we devised the assessment and devised the programme, we felt very strongly that a clinical interview, whether it's done by phone or face-to-face, is an essential component, because research has shown that more distress is detected in a proper clinical interview by a trained psychological or mental health professional than can just be elicited through self-report questionnaires. So part 1 of the assessment, the patient completes the self-report measures. These are measures for clinical depression. The BHQ-9 it's called, and the GAD-7 is measured for anxiety. We have a bespoke pre-transplant well-being questionnaire that Sarabi and I put together, and again it was further developed by Gary and Heather's participation, which is asking about the patient's understanding of illness, the perception of it, perception of support, perception of ability to cope, and things like the degree of optimism versus pessimism or fatalism. And I think it was at Gary's suggestion, possibly Heather's suggestion, we added in some other questionnaires from the sickle population called Ask Me questionnaires, which aren't about transplant, they're more about the impact of the sickle disease itself already. But we thought this would be some interesting data around impact of illness on pain, social functioning, fatigue and cognitive functioning, particularly if this can be followed up at a later date to see what's changed. This is what we thought would be particularly interesting. Just something about neurocognitive functioning in the wider pathway group that was meeting ahead of these transplants starting at King's. There was kind of unanimity, I think, that in an ideal world, sickle patients would have a fully fledged neurocognitive assessment before transplant to get a baseline, and that would be followed up at a specific time point further down the line to see if anything had changed. Now, unfortunately, at the moment, the resources are not available to conduct those fully fledged neurocognitive assessments. That's the GAD questionnaire that I mentioned. I won't dwell on it. You can look in that. I'm happy for you to see the slides. This is our bespoke transplant wellbeing questionnaire, which is completely pointless me putting that on the slide because you can't see it. I'm going to read out the questions briefly. Question number 1, how clear is your understanding of what the transplant will involve? And we give them a range of kind of multiple choice answers. How optimistic do you feel about the success of the transplant? How do you feel about your ability to cope with the transplant overall? Do you feel you can rely on the support of people in your personal life? How often do you worry about your sickle cell disease and treatment? How much confidence and trust do you have in the healthcare professionals looking after you? And is there anything else you would like to tell us about yourself that you think would help us to understand you better and care for you better? So those self-report questionnaires are usually completed in advance, but these are discussion tools rather than diagnostic tools as far as we're concerned. Part 2 of the assessment is a semi-structured clinical interview, as I described. So this is a bit of a repeat from the factors that I've already described, but these are the specific questions we ask in our face-to-face assessment. We ask about social circumstances and support, current mood, emotional state of concerns. We ask some questions about typical kind of coping style and coping. What are your preferred coping strategies? How have you coped with problems and adversity in the past? We take a history of current or previous serious mental illness or psychiatric diagnoses, including any treatment. We always ask questions about the risk of suicide or self-harm. We specifically ask a question about trauma, whether the patient's experienced any traumatic events or history of PTSD. I should say at this juncture, we deliberately do all this in quite a brief and circumscribed way, because of course we can speak to the patient again. So this is not a 2-hour assessment. This is an assessment that takes 30 to 60 minutes, and we ask about all of this stuff in a very circumscribed way. So I might say to a patient, you needn't feel at this moment that you need to elaborate on your past trauma, but it would be helpful for me to understand whether you think that's still a problem for you, and if it's helpful to elaborate at a later stage, we can of course do that. We ask about alcohol or substance use and behavior and history, the neurodevelopmental problems that may affect social interactions, or indeed the way we administer care. And sometimes information elicited in these assessments has led to us developing so-called patient passports to give some instructions for nursing staff about how patients like to be interacted with and cared for. We ask about safeguarding issues, phobias, and concurrent stressors. After the assessment, this information is typed into a document. It's placed on the patient's electronic record, and of course we will draw the routine ones not necessarily so, it's there for people to see, but the more complex assessments where there clearly are some psychosocial risk factors that are relevant, we will draw the team's attention to our assessment to give it some consideration about what we need to do next in terms of preparing the patient for transplant, or us offering some intervention as therapists. Yeah, as it says there, if indicated, in other words, if there's moderate to high distress, or potentially to help with preparedness, if there's a lot of ambivalence about transplant, we may offer some early psychological therapy or intervention. Could be immediate. It could be some patients will say, you know, I don't want it now, but it'd be great to see you once we're in. Post-transplant therapy is always available. Again, that usually comes from the HEMONC service, but over time we would then think about with our sickle cell psychology colleagues whether that support might be better off coming from them. Currently, it's still bedding in, to be honest, but in the post-transplant clinic here at King's, routine distress and quality of life screening is taking place using the IMPARTS platform. So that is one way of kind of tracking what's happened to patients. Other than that, at the moment, we are not purposefully following up every transplant patient other than through IMPARTS, because we don't have the resources to do so. Data so far, since the screening or assessment program has been up and running, we've had 5 referrals. I hope this corresponds to the number of patients that everybody else thinks we've seen. So we've had referrals for 5 patients, which isn't a huge number yet. Obviously, we're expecting it to grow. And this is what has happened with our patients without going into masses of detail. Patient number 1, during their assessment, found that they had moderately severe depression, no significant anxiety. They declined pre-treatment intervention, and they did not want any support during or after their transplant. Patient number 2, moderate depression, no significant anxiety. They had 1 follow-up psychology session, and then it was actually decided that this patient would not be transplanted yet, so it was deferred. Patient number 3, again, moderate depression was picked up on assessment, but no significant anxiety, interestingly. Same with all of those so far. They declined pre-admission intervention from our team, but actually then subsequently they had 2 inpatient psychology sessions and 2 sessions after discharge. Patient number 4, again, this time moderate anxiety on assessment, but no significant low mood, and they didn't want any input from us at all, or it wasn't needed. Patient number 5, moderate anxiety on assessment, no significant depression, but they did want or need 4 sessions of psychological therapy during their inpatient admission. There's another patient that came before the programme was fully underway that I'll just mention very briefly, but obviously without going into masses of detail. She had a transplant some time ago. It's been very successful for her sickle cell disease, and in the post-transplant clinic, very significant distress and very significant trauma was picked up by one of the post-transplant consultants who did a brilliant job at picking that up and referred to our team. And even though some of the trauma was not directly related to the transplant, we felt ethically, excuse me, and professionally, it was the right thing to offer this patient therapy. And she has been seen by a member of our team for some months for a very in-depth and protracted piece of psychotherapy. I think that's testament to the very kind of flexible model that we're prepared to offer and are able to offer in our service. These are my references. And that's me done. I hope I haven't overrun.
Thank you. Thank you very much. You've done very, very well. That was a really excellent talk. Are there any very quick questions before we press on to Victoria's presentation? Is Victoria Potter here?
Yes, I am. I shall
very
attempt
good.
to share my screen.
You can start sharing your slides while we have any other thoughts about psychology. You talked about your assessments. How much do you go into how they will be able to comply with treatment in terms of taking the post-transplant immunosuppressant?
Yeah, we do ask about that, and thus far, you know, yeah, we'll be fine. Yeah, we will do that. You know, we're used to adhering to demands and rigors of medical treatment. Nobody's raised any concerns or any doubts about that. We haven't picked up anybody with a history or pattern of non-adherence.
Yeah,
most people haven't been phased. That's the one thing I didn't say. Perhaps I'll say very quickly before Victoria starts. It's a very small number, but most people seem motivated, positive, possibly slightly ambivalent, but that, you know, degree of ambivalence is completely natural. But people are not anti, they're not negative, they're not too worried, not resistant. People have seemed pretty motivated, and I appreciate it's a very small number.
Brilliant. Thank you very much. So the last talk today is by Victoria Potter, who leads the transplant programme at King's. She was very instrumental in getting stem cell transplants for the reduced intensity ones for adults, funded by NHS England, so that's wonderful. But she's going to talk to us about haploidentical stem cell transplants and the redress trial. Thank you very much, Victoria.
Thank you, and thank you very much for the invitation to talk about this today. So, is my slide moving? Hang on, let's make this work. Okay, so Spanner's already given us a lovely talk today focusing on transplantation and talked a lot about sibling, but this was a very good thing that happened a couple of years ago now, which was finally the NHS commissioned transplants for patients with sickle cell who had a fully matched sibling. And the reason that they did not commission it for any other type of donor, say a haplo and unrelated donor, is that when the whole evidence review happened as part of this process, NHS England felt there really wasn't enough evidence to say it was good enough to take forward for routine commissioning or something that we could routinely offer to the patients. But one of the problems about having only sibling transplants, and this is that very first study, and Sabana showed you some of this, was that actually when you look at how you screen patients, so here they had 10 patients who had a transplant, but actually look at where they started. They had 112 patients and they screened 169 siblings, and 88 of these 112 patients did not have a fully matched donor. So this is actually a real problem, and while it's fantastic to be able to say that we've got a transplant option for adults with sickle cell disease, we don't actually have an option for a lot of them because they won't have a fully matched donor. And so this has really led to the development of haploidentical approaches, and these are half-matched donors that are related. And the definition of a haploidentical donor can be anything from a 5 out of 10, 6 out of 10, 7 out of 10, or 8 out of 10 donor. Now, this is this particular study, and this is essentially how you do a haploidentical transplant. And the backbone of being able to safely do a haploidentical transplant is being able to give post-transplant cyclophosphamide. And that's important because these are half-matched donors, and I'll come to that. But you can already see, and Sabana did show you that sibling protocol, that there's a bit more to it than that. So there's ATG, there's fludarabine, there's 2 doses of cyclophosphamide. These are fairly light doses of chemotherapy and generally relatively well tolerated. There's a very small dose of TBI. But then on days 3 and 4, you get this cyclophosphamide. And the reason that this is important is that when you give these half-matched donors, you get a lot of T cells that are recognizing the patient and the tissues of the patient as very, very foreign. And those T cells proliferate, and they rapidly proliferate. And the risk is that they will cause very, very severe graft-versus-host disease, which would be a bit of a disaster, really, for the patient. And so what this administration of this cyclophosphamide on day 3 and day 4 does is that it destroys these cells, these ones here that are rapidly proliferating. And what also happens is that there are these other cells that do not react that well, that just persist. So you still get some T cell immune reconstitution, so you still get the development of immune system, but you've destroyed these ones that are likely to cause very, very severe graft-versus-host disease. And this really came to light kind of more than 10 years ago as a safe way to be able to do haploidentical transplants. And it started in the malignant setting, and that led this other group to see if they could replicate this in the non-malignant setting. So that's that. So in this, they piled this in 19 adult patients, and you can see here already, even though the numbers are small, of the 19 patients, they are actually able to transplant 17 of them. So it is a true thing that most patients will have a haploidentical donor. So a haploidentical donor can be a child, it could be a mother or a father or a sibling. Sometimes it could even be a cousin. But you can see that you've got many more opportunities to have a half-matched donor than you do to have a fully matched sibling donor. So in this group of adult patients, they had engraftment of 11 patients. There seems to be some thunder going outside my room. I don't know what that is, but I'll talk loudly and hope that you can hear me. And so there are a couple of good things about this. GVHD didn't really happen. So there was only one patient that had low-grade GVHD resolved without needing any treatment, and no patients actually died. So the protocol was actually very, very safe. The problem here was that if you've got 11 patients, only 11 patients who are getting durable engraftment, quite a lot of your patients are actually failing. So you put them through a whole horrible transplant and they don't get the benefit because their sickle cell disease is not cured. And they may have had some complications from that transplant. So this really needed to be improved upon. And the way that it's been improved is by adding additional chemotherapy. So I told you before, there's quite a lot of drugs in it, and a couple of different groups have done a couple of different things. So this is one group of which Hosu has been involved in. Many of you will know him, that augmented this protocol by adding in this extra chemotherapy of thiatepa. That's this 1 dose of thiatepa here. The rest of the protocol was essentially the same. A different group has augmented the protocol by increasing this dose of TBI. So they've had to provide additional drugs or TBI to get this to work. And this is just to show you this actually works. So in this study, all of these patients were alive, and the event-free survival, so this is people who are surviving without graft failure, is actually very, very high. So great success in terms that you can actually get this protocol to work, but you can see how it is more intensive, and that may create some problems with delivery. GVHD rates were not particularly high either, so again, reassuring that you could deliver this with relatively minimal complications. So this has now led us to develop what is called the REDRESS trial. So this stands for Related Haplodonor Hematopoietic Stem Cell Transplantation for Adults with Severe Sickle Cell Disease. And redress is a good name because it kind of feels a bit like redressing the balance, and it fits the trial acronym, and that's thanks to Ben Carpenter, who came up with that name. So one of the things that came out of the commissioning policy and the evidence review was the fact that there wasn't enough evidence to commission haplotransplants. And so one of the results of that was the NIHR actually put out a call and said, we want to look at transplantation. And so there was a brief, and as a group, we've managed to apply for this, and as a national UK group, so this was all transplant people interested in it, working with sickle cell physicians. So it's a fantastic kind of collaborative effort. And somehow we've managed to get lucky, and we've been awarded this grant to actually take this trial forward. And one of the briefs of the commissioning was that we look not only at the clinical, so does it actually work and does it cure, but we also study the cost effectiveness of haplotransplants, because that's actually quite important. And one of the arguments that clinicians and particularly transplanters have liked to make about this is that actually, if you're a sickle cell patient with severe sickle cell disease, you're becoming in and out of hospital all the time, and the costs to the healthcare service are actually quite high when you factor in the costs of a chronic illness and multiple hospital admissions, and that although the cost of a transplant to the NHS might also be high, it could well be that that one-off cost of a transplant by curing the sickle cell disease outweighs subsequent costs of ongoing care for patients with sickle cell disease. So that's kind of been one of the major arguments that we tried to make, to say, look, we should have this as an option. So that went in the brief, that they wanted us to actually also demonstrate whether this is effective. So it's a multi-center trial, and it's a randomized trial. So that means not everybody who enters this trial will actually end up having a transplant. And the inclusion criteria, which I'll show you in a minute, mirrors that of the NHSE commissioning policy that currently exists for siblings. We are using that Vanderbilt protocol, and that is the protocol that I showed you earlier, the one that's had the thiotepa added into it. And we're hoping that the first patients will receive transplants by September, October of actually 2022, not 2023, but that's actually getting a little bit close. And if this works and this is successful, hopefully we will have managed to expand the access to transplant for those patients without a fully matched sibling donor. So the protocol looks like this. So patients will be randomized, looking to recruit 120 patients. Half of them will have a haploidentical transplant, and half of whom will continue their standard of care. And that includes any treatments for sickle cell disease that are available to be delivered and prescribed within the NHS. The patients will be followed up for 2 years post-randomization, and then obviously we'll hope to publish this and disseminate it widely so that everybody knows what the results were. This is just a reminder. Here's the protocol again. So it's actually, I think, reasonably intensive for patients to go through, and we'll need to make sure that these patients are counseled differently to patients who are receiving a transplant from a fully matched sibling donor. So basically, you need to be an adult and you need to have a haploidentical donor available. And very broadly, this is for patients with a severe sickle cell disease phenotype at high risk for morbidity and mortality. I won't go through each of the individual ones there, but these are reasonably standard, and actually they are reasonably inclusive. There's a slightly vague criteria at the end, which is about end organ damage relating to sickle cell disease. And we thought that that needed to be ratified by the UK National Haemoglobinopathy Panel. The reality is that every patient who's going to be off this trial will obviously be discussed at the National Haemoglobinopathy Panel anyway. But for end organ damage, we made it very explicit. And that last line says patients must be it, but actually that's patients must be fit. So there are parameters about cardiac fitness or lung fitness that a patient would need to meet to be able to have a transplant. The exclusion criteria are: if you have a fully matched sibling donor, you will certainly not be eligible. We are not going to offer this to patients who had a previous transplant, and that's actually relevant if we have patients coming along who perhaps have had a sibling transplant that didn't work. So we have actually excluded those patients. Clearly, people can't be pregnant, breastfeeding, or unwilling to use effective concentration. One of the things with haploidentical transplants that puts that transplant at risk of working is if the patient, the recipient, has HLA antibodies that are directed against the donor. And so if there are donor-specific HLA antibodies, we will not include those because it's too risky from a graft rejection point of view. We won't include active infections, and we are required to exclude people who've been in another interventional trial within the last 3 months. But 3 months is, I think, a reasonable time frame. So the inclusion-exclusion criteria are actually, I think, reasonably good and shouldn't exclude too many people who would want to consider this. And so really what we're trying to do, and the primary objective, is to assess the clinical effectiveness of haplotransplants when compared to the standard of care for severe sickle cell disease. And the definition of this is treatment failure or mortality, and that's defined as treatment failure is defined as occurrence of a vaso-occlusive crisis or transfusion from 6 months post-randomization. And the reason that we've chosen it to be from 6 months is that you may well have a transfusion as part of your transplant care, and therefore we won't really be able to assess whether that's a proper endpoint if we start to assess that too early. The secondary objectives are to look at the cost effectiveness, as I talked about before, to evaluate the complications of haplotransplant compared to ongoing complications of patients who have sickle cell disease who don't get a transplant, to contrast, to compare both of these groups on quality of life, because that's really important. We want transplants to be curative and we want it to improve a patient's quality of life as well. We want to determine the overall treatment success in terms of sustained engraftment and cure of sickle cell disease phenotype. And we also want to describe the characteristics of the transplant participants, and I'll come to that in a second. So this is how you define the secondary endpoints. So health-related quality of life, healthcare utilization. So a lot of data we collected on hospital admissions, things like opiate use. We obviously need to look at death, and we want to look at death for any reason, but also if that's specifically related to sickle cell disease or to transplantation. We need to measure things like the HbS percentage. We want to look at the complications, transfusion requirements, etc., etc., etc. So there's quite a lot of things that are going to be collected as part of this. For the transplant population specifically, because these are outcomes that we are only going to be seeing in one arm, time to neutrophil and platelet engraftment, important. Graft versus host disease, really, really important. You've probably heard me say this before, it's really important to minimize GVHD in this criteria, in this particular indication. We want to look at infectious complications. Transplants can increase the risk of infectious complications, so we need to know what's happening there. We'll look at the specific donor chimerism. We want to know whether patients can come off immunosuppressive drugs, because actually if you go through a transplant, you should actually ultimately be able to stop your immunosuppressive drugs. And so that's quite an important endpoint from the transplant perspective. And as I said previously, we need to look at transplant-related mortality. It's a fairly ambitious trial when you think that we're actually going to recruit 100 patients and we're going to be talking about patients being randomized to a potentially intensive intervention versus actually no intervention at all. And these are patients with severe sickle cell disease. And, you know, I think we all recognize that patients may actually find this quite challenging. So there's, as part of this trial, we've been asked to build in an internal pilot to say that whether we can proceed. So by the end of the first year, we've got to have opened at least 5 sites. And we need to have tried to have randomized at least 1 participant. And we want to see an average recruitment rate per site per quarter as well. And if we're not meeting those, then the trial will probably be asked by NHR to shut down the trial. So the first year is probably going to be, I think, quite important in this. So that's all I was really going to say for now, because I thought it'd be good to have a little bit of time for questions. But there's so many people involved in this, and I've probably actually forgotten to put some names, but it's truly a joint effort with everybody really contributing. And we've had fantastic support from the Sickle Cell Society, and we've got a great group of patients who are also really, really engaged as our patient advisory group as well. So thank you. There's an email address as well if you're interested to email the trial email address and ask any questions you want. And we have a Twitter account, which we're just starting to use, but we'll try and get better at it. So questions?
That was really wonderful, and it's I'm impressed you've got a Twitter account as well as a special email. That was very clear. Any questions from anybody? You came in perfectly on time, so we've got 5 minutes for questions. I might have missed it, but when do you think you'll start recruiting the first patient?
So theoretically, we should be starting by September, October this year. That's quite a tight timeline.
Very exciting. I can think of lots of people that will want to take part. I suppose there might be some reluctance to be randomised to nothing, you know, to just continuing their on management. But I suppose we'll have to see how that goes. John, you've got a question?
Yeah, well, 2 questions. One was, is there a upper age limit to both the donors and the recipients as to how old they can be to be used in the trial? And also that question exactly that what happens to the patients who really want to transplant and get randomised to standard of care? Can they go? Will they end up going to another hospital and trying to re-enroll, or you know, what's the?
Well, that, I mean, that's quite cool. I hadn't thought of that later part. So to answer the first question, there's no age limit. There's no upper age limit. But I think that, you know, we would assess anybody upon their organ fitness, but, you know, we probably don't really want to do people that are too old, but I think we'll have to make individual decisions, but there's definitely no upper age limit. There's no upper age limit for the donor either. All of the donors will have an independent medical as would normally be performed, and as long as they meet donor clearance, then they would be eligible to be a donor. The fact of the matter is that as people become older, as donors become older, it's more likely that you might find a comorbidity or something that then makes them not eligible to donate. And I think the other thing is if you're, say, using, say, for example, a young male donor that has obviously never had children might be preferable to a donor that is a mother that might have had 5 other children and therefore be primed and give a higher risk of GVHD. So if there are multiple haplo donors, you might be having a conversation about which would be best. Unfortunately, there's no provision if you get randomized to the control arm to go off and have a transplant. And the best chance we have of getting this commissioned is enrolling people on the trial and showing that it works, and then having it as an option available. And patients may go off somewhere else and try and get on it, but I feel that it will get flagged in the database system, which is all computerized by, you know, dates of birth and things would match up. So it'd probably be quite hard.
It's a good point. They won't just be able to present to another centre because you'll have their name on record as having been randomised. Any more questions? Can I ask a quick question? I wondered how good stem cells are from a certain age upwards. If you've got older donors, because some of our adult patients, their parents might be quite elderly.
Yes, indeed. So we would always prefer a younger donor where possible, because younger stem cells are probably likely to be better. But we have been using older siblings for many, many years, and we know that, you know, that works. There have been a couple of studies in the malignant setting where they've tried to compare the results of an older sibling donor versus a younger, you know, super young, well-matched, unrelated donor. And those studies are a bit contradictory. Some of them suggest that the well-matched younger donor is better, but I think it's a hard call to say. And we certainly wouldn't exclude somebody unless they had a health issue.
Because I was thinking some of our patients in their 30s or 40s might have parents in their 50s, 60s, 70s, but you'd still be interested in that sort of age group.
50s and 60s, not so worried about. Once someone gets to 70, then we might try for another one. If that adult patient in the 30s, we would go for their siblings first. So we'd try for the youngest available donor.
Wonderful. Right. Anyone else with a question? Otherwise, we've come in perfectly on time at 5 o'clock. What very obedient presenters. Well, thank you so much, everyone, for dialing in. Dowd wants me to remind you that we've got to try and fill out a satisfaction survey, just a few seconds, and it's in the chat. You can just click on the link and it takes you straight in very cleverly. So if you could all try and do that before leaving, that would be very much appreciated. Otherwise, thanks a lot all for joining. And thank you very much for the presenters for such concise and clear presentations.